We lose our discriminative touch, our proprioception. We have upper motor neuron signs. On the contralateral side, we have loss of pain and temperature because they've already crossed. The interlateral tracts have already crossed, but the DCML haven't crossed yet, and the corticospinals already have. Yep.
So one thing we were thinking is that it possibly could be bilateral pain and temperature, because if it was a complete transection, wouldn't that also include the anterior white commissure?
Yeah, but it's really of one side, so it's only part of the commissure. So theoretically, with Brown-Séquard, you might have bilateral loss of temperature where? Below?
At that level.
You could lose it at that level because of that.
Okay.
Again, the bigger problems are going to be the whole lower extremity. On the contralateral side isn't going to have it, and so even if we lose it, you'll lose it maybe a little pain and temperature on the contralateral side at L1. So you might. So again, and then when we do this next year in spinal cord, you'll see you have to really do a pretty thorough sensory exam to figure out what levels, and they're not always completely symmetrical. Yeah?
When you're talking about the anterolateral horn and having pain,
It's not a horn, it's a tract, but go ahead.
Sorry.
That's okay.
Would they have, when you say pain, are you saying that like if you pinch them on that side they wouldn't feel it, but do they have nerve pain on both sides, or it just depends, or?
They don't have necessarily nerve pain. No, it's just that they don't have pain sensation. So they actually they're insensate. So the problem with these folks is they're going to get a cut, they're going to break their leg, and they're not going to know it. And when we, again, when we talk about the visceral motor and dysreflexia, you've got this big pain sensation, and they don't have all the responses that we need to have in response to that. Yep.
Do they just not have that sensation at all, or impaired, or is it like impaired, like if you?
It could be, you could have a partial preservation. We're assuming, if it is a true Brown-Séquard, they won't have it at all. Absolutely none. So, and if you have a complete transection of the spinal cord, you'll have absolutely none. But an incomplete lesion, they could potentially have some preservation.
So when you have a complete transection, you also affect the anterior one, which is the lower motor neuron. So at L1, how is there, like, you know what I'm
Yeah,
saying?
at L1, theoretically, you might not have a reflex arc. You might have just one area where you have absolutely no reflex. And that does happen. Not. It depends how large the lesion. I mean, if it's a really big bleed or a really big compression, yeah, you would probably see some lower motor neuron right at that lesion, and then upper motor neuron everywhere below.
All right, and also another question is, so the DCML, you look light touch up there, is it crude also, like,
Yeah.
you can use it for light touch, wouldn't that just be anterior lateral? Spinal flank? So should it be discriminative touch?
Yeah.
Yes. Mm-hmm. Yeah, I'll fix that.
Okay.
Mm-hmm. I will change the word to discriminative because that's really what it should be. Because light touch is actually more anterolateral.
Okay, yeah, crude, right?
It's crude, it's tickling, it's not. All right. So here we've got our Brown-Séquard. Again, what we're losing dorsal columns, which ends up with impairments on the ipsilateral side. Corticospinal, again, it's already crossed, so ipsilateral, upper motor neuron below. And then intralateral, they've already crossed on their way up, so now we have contralateral loss. So I'm going to skip to this. So this is Brown-Séquard.
That's awesome.
Okay.
That's what it is.
It's awesome.
I'm jumping around. We're probably not going to go through all of them.
Great job. Shut up. I got an email now.
Oh, I need to get my
Textbook.
Yeah. Wait, is Sherry teaching? Yeah, no problem.
Just please bring your textbook.
All right. When you ask your patient to reach for an object, you note that he shakes throughout the movement and has a difficult time targeting the object. Muscle tone is decreased and speech is slurred. Sensations intact. How might you explain this one?
Something cerebellar, because it's the intention during the motion of spinal cord. Initially, I haven't read the question. Sometimes you can turn it and don't get it.
Yeah, what was that one?
I'll be stuck.
Damage to
Maybe we can
spinal cerebellar tract? Yeah.
wait, but why can't I see it?
It is spinal cerebellar because she has dysarthria.
Yes, ma'am.
Hey, listen, I'm just
Nick
trying
has a list memorized. This week's say dysarthria, like dyspnea.
cerebellum, like dysarthria, dysmetria.
Because like this Friday, I was very
This party, the theme is dysarthria.
You better be A-taxing, by the way.
We ready?
You're
Going back again. Nathan. It's Nathan's turn.
Alright. So, the damage is to the cerebellum,
Okay, why do you say that?
because you have the third speed, dyspnea, and intention tremor.
Okay, yeah, intention tremors, dysmetria, and dysarthria. So this is an extrapyramidal lesion. So what else might you expect to see in this patient? And he has decreased tone, which also kind of clues you in a little. What would you expect? Anything else? Why would you expect a spinal cord injury?
Didn't you say the other day that initially, like from the inflammation, he'll get flaccidity instead
Oh.
of spastic?
With the low tone, that's a good point. This, you wouldn't have the dysmetria and all that. But when you have an acute spinal cord, you typically do see a period of spinal shock where they are flaccid because of all the inflammation, and then the spasticity emerges. But you don't see the dysmetria and the slurred speech.
Why do you have low muscle tone with cerebellar?
It's the postural tone. It's the vestibulocerebellum that kind of just lends to. So it's not a lower motor neuron or anything. It's just the ability to maintain muscle tone. You're not having a sustained, coordinated contraction of the muscle. So, and it qualitatively is different. When someone has a real lower motor neuron lesion, like a brachial plexus injury or polio or something, not that I've ever seen, I've seen post-polio, I've never seen polio. But brachial plexus injuries, it's just a complete, for them, I've seen someone with a true brachial plexus, they're just complete atrophy, extremity, complete dead weight, lots of swinging, that kind of thing. And with a cerebellar, it's sort of, it's not that extreme. I heard somebody saying spinocerebellar tract. Somebody said it.
Nick said it.
Why'd you say that?
Because you said targeting the object, so I figured reaching.
Because he has the plan. It's executing it.
And I thought it'd be like,
Because
Shaking
your point is actually very interesting, and because what does the spinocerebellar tract do?
smooth movement.
It's not motor. Spinocerebellar goes up.
Position of motion.
Is it a sensory or is it motor?
You said
I
it
heard
was motor,
both.
so-
I already said it wasn't motor. Spinal. If anything that starts with spinal, like spinothalamic, spinocerebellar, starting there, going up. Sensory. So, and what's it carrying?
Position of motion.
Subconscious proprioceptive information. So you're right. If somebody is not getting correct proprioceptive information, they are not going to have smooth movement. They are going to have problems like dysmetria. And you do see that. You do see that with some, if they have certain spinal cord lesions, you will see some of these cerebellar-like symptoms because they don't have that subconscious proprioception. So you can kind of see by the quality of the movement, this person has a proprioceptive loss. but this was a little more simple than that. This was just cerebellum.
We have in the notes that the spinocerebellar tract is motor execution.
Spinal cerebellum is motor execution. That's a region of the spinal cord. I mean, of the cerebellum, I'm sorry. The region of the cerebellum has a vestibulocerebellum, a cerebrocerebellum, and a spinocerebellum.
What were you saying before that?
The spinocerebellar tract. They were in the somatosensory lecture. Lecture before. All right, this is actually, because the terms are almost exactly the same. Spinocerebellar tracts, we have the dorsal and ventral spinocerebellar tract, and we have the cuniocerebellar tract. The dorsal and ventral spinocerebellar tracts carry information from those muscle spindles and those joint receptors and those Golgi tendon organs up to the cerebellum, so that the cerebellum is getting a constant sensory input of what's happening. Those are the spinocerebellum tracts. The spinocerebellum is the region of the cerebellum that's going to communicate with the spinal cord for executing. So we do have some access to lower motor neurons from the spinal cord. So that is the motor execution. So it's a region of the cerebellum. Those are the nuclei versus the spinocerebellar tract, which is carrying information from, sorry, I didn't write the word.
No, that's fine.
So could you say this is specifically a spinocerebellum? Affecting specifically the spinal cerebellum of the cerebellum.
I would argue maybe the cerebrocerebellum as well a little bit. The only thing I didn't put in this case is anything vestibulocerebellum.
Okay.
But in reality, they probably have some balance issues too. Do you guys want to do one more, or you want to?
Let's do it.
Let's do one more, and then the rest are up here, so you can play around and go by lesion or go by case. There's 7 cases, and there's like 8 or 9 lesions, so you can go either direction. I thought so.
Up on Friday, Saturday, Sunday.
I think that's at 10:30.
Oh, that's
Okay. I don't want to do this one.
Always. Typically I don't.
Typically I do.
Is this nice?
Oh, all right. Here we go. Let's try this one. Your patient presents with bilateral weakness that began in his feet. It resulted in him falling. He was clumsy. His weakness has progressed to more proximal muscles, and he's now on a ventilator. He had a flu about 2 weeks ago. Sorry. This is get out of the trees and look at the forest.
He's blind.
Guillain-Barré, yes. I just wanted to, you guys, good job. I heard, but exactly, I wanted to not, because I didn't want you to sit there going, okay, well, it's lateral quarter. No, okay. This is the classic Guillain-Barré presentation, where again we start distally, and then end up with proximal loss, and we recover proximal to distal, and so this is Guillain-Barré. Wanted to make sure your brains were still keeping the old stuff. So this is again degeneration of or an autoimmune attack on the Schwann cells. Yep.
Is the flu relevant?
Say it again.
Is the flu relevant?
Yes, the flu is relevant because the majority of cases of Guillain-Barré had some type of infection within 2 weeks of the incident. So it triggers, that infection is thought to trigger the autoimmune response. Not everybody, but the majority do. So, very classic history. All right, so have fun with it. I will fix that one little light touch. Some things sound good. Some things